Welcome to the woolly world of liver disease, where billy goats are bilirubin and choledocholithiasis is a swift kick to the ribs. We're starting with the big picture, a DDX of abnormal liver labs. First, we'll introduce the cast of characters, the individual lab tests. Then, we'll organize lab abnormalities into three separate patterns: isolated hyperbilirubinemia, hepatocellular, and cholestasis, covering the differential for each. Let the fun begin. The standard panel of liver tests is sometimes referred to as LFTs, or liver function tests. This is a bit of a misnomer because many are markers of liver injury, not liver function. How do you know who's who? We're getting to that. Aspartate aminotransferase, or AST, and alanine aminotransferase, or ALT, are markers of liver injury, in particular, hepatocellular injury. Hence the name, Pat and Sal's. Both AST and ALT are intracellular enzymes, normally contained within hepatocytes. But when hepatocytes are damaged, they leak into the serum. At Sketchy, elevated malt glasses are our recurring symbol for elevated ALT, while that perpetual toast represents elevated AST. There's considerable debate about the optimal upper limit of normal for ALT and AST. According to the guidelines, a normal ALT is below 25 in females and 33 in males, lower than the upper limits used by many laboratories. Alkaline phosphatase, represented by this chalk bucket and chalkboard, is another important marker of liver injury. This enzyme is found in hepatocytes along the bile duct membrane. In particular, it becomes elevated in response to bile duct stasis, aka cholestasis. Alk phos is also present in high concentrations in tissues outside the liver, particularly bone. As a result, an elevated serum alk phos can also be a consequence of bone disease. The hepatic origin of alkaline phosphatase can be confirmed by measuring the serum level of a second enzyme, gamma glutamyl transpeptidase, or GGT, symbolized at Sketchy by a GGT gadget knife. GGT is also elevated by cholestasis, and levels usually correlate with those of hepatic alkaline phosphatase. GGT is not elevated in bone disease. That covers the major markers of liver injury and cholestasis. Let's move on to liver function, which is assessed by looking at markers of synthetic function. The liver is responsible for synthesis of most serum proteins, including albumin and coagulation factors. Impaired synthetic function is represented here by this gnarly dysfunctional liver shrub. Yep, just not synthesizing like it used to. Two readily available lab tests are used as markers of synthetic function. The first, serum albumin. Impaired synthesis presents with hypoalbuminemia, represented by these falling album pages. The second marker of synthetic function is the prothrombin time, or as this announcer seems to prefer, the INR, symbolized by that intercom radio thingy. These tests reflect the activity of the extrinsic coagulation pathway. And conveniently, all of the factors in this cascade, 1, 2, 5, 7, 9, and 10, are synthesized in the liver. Impaired production leads to a prolonged prothrombin time and an elevated INR. We've saved the best test for last, bilirubin. At Sketchy, when you see billy goats, think bilirubin, of course. Bilirubin is derived from metabolism of heme, as illustrated by the stack of old heme hubcaps. In a healthy person, breakdown of old red blood cells leads to a small amount of unconjugated bili in the serum. Unconjugated bilirubin travels in the bloodstream tightly bound to albumin in order to increase its solubility. The hepatocyte converts unconjugated bili into the more water-soluble conjugated form. And finally, conjugated bilirubin is excreted into the bile ducts. The standard liver panel includes only the total serum bilirubin, the sum of both the unconjugated and conjugated forms. The total is normally less than 1. The lab can also measure the direct fraction, which approximates the conjugated bilirubin. Subtract the direct from the total to get indirect, which approximates the unconjugated bilirubin. From a clinical perspective, an elevated serum bilirubin always falls into one of two categories. The first, unconjugated hyperbilirubinemia, is, well, what it sounds like: the elevation of predominantly unconjugated bilirubin, also called indirect bilirubin, represented by this uncolored billy goat. If the lab is using older methods, they may also report a small amount of direct or conjugated bilirubin, even though the patient, in reality, has unconjugated hyperbilirubinemia. This is why we've placed this direct map under the uncolored goat. Don't be fooled though. This is a result of unconjugated bilirubin reacting with the direct reagent. Yep, just some unconjugated bili pretending like it's conjugated. As long as the direct is less than 20% of the total, you can assume that the bilirubin is predominantly unconjugated. Unconjugated hyperbilirubinemia is seen in conditions unrelated to the liver. For example, increased bilirubin production by hemolysis. But it can also be produced by liver disorders that impair bilirubin uptake or conjugation. More on that later. The second pattern is, well, conjugated hyperbilirubinemia. The serum bilirubin is never 100% conjugated, however. Instead, elevated conjugated bilirubin is always accompanied by elevated unconjugated bilirubin, which is why this conjugated collared goat is accompanied by his uncollared friend. A few reasons for this. For one, buildup of conjugated bilirubin within the hepatocyte actually leads to reversal of the glucuronidation reaction. So, some of that conjugated bilirubin is converted back into the unconjugated form. In addition, intestinal bacteria also convert conjugated bilirubin back to the unconjugated form, which is then reabsorbed back into the bloodstream. So keep in mind that the term conjugated hyperbilirubinemia always refers to the elevation of both fractions. But going forward, we'll only show a collared goat to represent conjugated hyperbilirubinemia. Conjugated hyperbilirubinemia is a feature of both hepatocellular and cholestatic disease, which will be illustrated inside the liver pen and the adjacent grassy area, respectively. If you were to just look at the bilirubin pattern, these two categories of disease are pretty indistinguishable, actually. So, you know what? If your patient clearly has liver or cholestatic disease, it's often unnecessary to fractionate the bilirubin in the first place. You can just assume conjugated hyperbilirubinemia and move on. Another sign of conjugated hyperbilirubinemia is detection of bilirubin in the urine. Conjugated bilirubin is water soluble, remember, and small enough to be filtered through the glomerulus. In contrast, unconjugated bilirubin, tightly bound to albumin, is too big to be filtered. As a result, unconjugated hyperbilirubinemia does not lead to a positive urine bilirubin, unless the patient has albuminuria from glomerular disease, of course. Bilirubin in the urine may cause it to appear darker than normal, thanks to bilirubin's yellow-orange hue. Elevated serum bilirubin, regardless of whether it's unconjugated or conjugated, manifests clinically as jaundice. Slight elevations aren't noticeable. Jaundice becomes visible only once the total serum bilirubin reaches about 2, twice the upper limit of normal. Severely jaundiced patients may have skin that appears visibly yellow. Mild jaundice can be more subtle. On physical exam, it's most notable in 2 locations. First, yellowing of the whites of the eyes. This is sometimes known as scleral icterus. Although the conjunctiva, not the sclera, is the site of bilirubin deposition. Second, look for yellow discoloration of oral mucous membranes, particularly the hard palate and under the tongue. Alright, now that we've set the stage, farm, we'll take you through 3 major patterns of lab abnormalities and the differential for each. Pat and Sal's malt shakes, anyone? The hepatocellular pattern of lab abnormalities is seen in disorders of the liver parenchyma, where hepatocyte injury is the name of the game. Here, AST and ALT are disproportionately elevated compared to the ALK-Phos, hence the toasting malt shakes towering over the chalk bucket. The AST and ALT can range from mildly elevated, double digits, all the way to the thousands. What? As for the ALK-Phos, it may be normal or mildly elevated, less than 4 times the upper limit of normal. Boring. If ALK-Phos is mildly elevated, serum GGT is often elevated as well, hence the handy gadget knife leaning against the chalk bucket. Remember, GGT is telling us that the ALK-Phos is from the liver, not bone. Hepatocellular disease can be organized based on the time course and degree of AST and ALT elevation. Marked elevations of AST and ALT, greater than 15 times the upper limit of normal, meaning hundreds or even thousands, are usually a result of acute hepatocellular injury, represented by an acutely ringing alarm clock within the liver-shaped pen. Notice those prominent toasting malt glasses aren't far away. Here, acute means less than 6 months. Most patients with acute hepatocellular disease have some type of acute hepatitis. While the underlying disorder varies, viral hepatitis, alcoholic hepatitis, drug reactions, ischemic injury, etc. We refer to these collectively as acute hepatitis, represented by a racing goat kicking up sparks and flames within the liver pen. It's inflammation time. A more severe manifestation of acute hepatocellular disease is full on acute liver failure. A bit like this goat. Ooh, faceplant. Yep, that's a fail. Acute liver failure, by definition, requires the presence of hepatic encephalopathy and an elevated INR. Let's step back to acute hepatocellular disease in general. Back to that gnarly liver shrub. Impaired synthetic function is a sign of severe hepatocellular disease, acute or chronic. Recall that impaired synthetic function is assessed by looking for an elevated PT-INR and a decreased serum albumin. Here in the acute side of the liver pen, severe disease includes severe acute hepatitis and acute liver failure. In the acute setting, it's that change in PT-INR we look for first. That's because it becomes abnormal quickly. Clotting factors in the extrinsic pathway, particularly factor VII, have a relatively short half-life. As a result, just 24 hours of impaired protein synthesis will prolong the PT and raise the INR. Hence the sun logo. That's one sun for one day. When INR is elevated from impaired synthetic function, administration of vitamin K does not correct the abnormality. Think of it this way: no matter how much vitamin K you throw at it, a failed liver is a failed liver. This is in contrast to an elevated INR resulting from vitamin K deficiency, which will correct with vitamin K. We'll reiterate this later. In contrast to clotting factors, serum albumin has a relatively long half-life, as emphasized by the month-long calendar falling from the album. Protein synthesis needs to be impaired for at least 3 weeks before serum albumin levels begin to drop. So, expect a low serum albumin if severe acute hepatocellular disease has been going on for 3 weeks or more. Remember, by definition, acute liver disease can last up to 6 months. Here in the acute side of the liver pen, elevated serum bilirubin and jaundice are common as well, and not just in severe disease. Even relatively mild acute hepatitis can cause jaundice, as depicted by the acute liver failure kid and the acute hepatitis kid, both of whom are riding yellow bilirubin goats. The goat is colored to remind you of conjugated hyperbilirubinemia, of course. Injured hepatocytes are particularly bad at excreting conjugated bilirubin into the bile ducts. So bilirubin backs up, all the way into the serum. Patients with acute hepatitis or acute liver failure are usually pretty symptomatic. In addition to jaundice, common symptoms include right upper quadrant pain and nausea or vomiting. Goat sickness much? Patients with acute liver failure will also have hepatic encephalopathy, a defining feature of acute liver failure. Hepatic encephalopathy reflects the liver's inability to adequately clear ammonia and other neurotoxins. Most patients with the condition have an elevated serum ammonia level, although measuring ammonia is not required for diagnosis. Hepatic encephalopathy presents with altered mental status, ranging from mild sleep disturbances all the way to coma. Look for a characteristic physical exam sign: asterixis, a flapping tremor of the hands when the wrists are extended. Hence these flapping bird wings over here. An emu, huh? That won't end well. Alright, as you can tell, we're just focusing on the big picture here. Only the laboratory findings and major clinical manifestations of these disorders. Check out our acute liver disease sketch for a more in-depth discussion of the underlying causes of acute hepatitis and acute liver failure. Well, if there's an acute version, you bet your jaundiced hide there's a chronic version. This time, however, notice that the malt glasses are pretty normal sized. Chronic hepatocellular injury, represented by this chronically old grandfather clock, is associated with a mild to moderate AST and ALT elevation. That means less than 15 times the upper limit of normal, or to put more simply, double-digit numbers up to a few hundred. By chronic, we mean more than 6 months. Common causes of chronic hepatocellular disease include alcoholic liver disease, chronic viral hepatitis, particularly B and C, and non-alcoholic fatty liver disease. We'll discuss the differential and workup for these conditions in our chronic liver disease DDX video. Here, we'll focus on the big picture once again. We'll refer to the relatively early stage of these disorders collectively as chronic hepatitis, represented by this racing pony kicking up flames next to the grandfather clock. Over time, if chronic inflammation continues, liver tissue is replaced by fibrosis. That's cirrhosis, my friend, represented by this fibrosed concrete scar inside the liver pen. Just imagine flaming dirt over time turning into concrete. It's basic biochemistry, really. Or alchemy, maybe? I don't know. Let's take a look at some of the same features, now from the chronic side. Back to the gnarly liver shrub. Recall that impaired hepatic synthetic function is a sign of severe hepatocellular disease. Here on the chronic side, severe disease is synonymous with cirrhosis, in particular, decompensated cirrhosis, which is why we've placed the shrub low in the scene, on the same level as that concrete scar. Expect both markers of hepatic synthetic function to be abnormal in decompensated cirrhosis. Impaired albumin synthesis leads to hypoalbuminemia, while decreased production of clotting factors leads to prolonged PT and elevated INR. Notice the flapping emu's proximity to the liver concrete as well. Like acute liver failure, decompensated cirrhosis can cause hepatic encephalopathy. Once again, the liver is unable to adequately clear ammonia and other neurotoxins. But that's where the similarities between acute and chronic hepatocellular disease end. Recall that on the acute side, even relatively mild acute hepatitis commonly causes hyperbilirubinemia and jaundice. In contrast, here on the chronic side, early disease does not present with hyperbilirubinemia or jaundice. No jaundice on this horse. The development of hyperbilirubinemia and jaundice indicates progression to decompensated cirrhosis. As in other liver diseases, the pattern is a conjugated hyperbilirubinemia, hence the colored goat on the concrete slab. Once again, injured hepatocytes are particularly bad at excreting conjugated bilirubin into the bile ducts. Decreased bilirubin uptake and impaired conjugation can also contribute to the problem. Unlike its acute counterpart, chronic hepatitis is usually asymptomatic. So the racer in the chronic lane is smiling and symptom free. Decompensated cirrhosis, on the other hand, is far from asymptomatic. In addition to jaundice and hepatic encephalopathy, patients may present with evidence of portal hypertension, such as GI bleeding from esophageal varices and abdominal distension from ascites, and signs of hyperestrogenism, like spider angiomata and palmar erythema. For a more in depth look at the clinical manifestations of cirrhosis in all their gory detail, check out our cirrhosis soap sketch. That about does it for chronic hepatocellular disease. For the most part, laboratory tests we've mentioned aren't particularly useful in identifying the underlying cause of hepatocellular disease. But there's one exception: alcoholic liver disease. In the majority of hepatocellular conditions, the ALT is greater than the AST. In contrast, alcoholic liver disease usually presents with AST greater than ALT. In particular, a ratio of AST to ALT greater than 2 is highly suggestive of alcohol as the underlying cause. So, on the chalkboard in the back, we featured a wine bottle next to an AST toast. In addition, patients with alcoholic liver disease may exhibit significant elevations of serum GGT without a corresponding elevation in alkaline phosphatase. Heavy alcohol consumption itself is responsible for increasing the GGT, an effect seen even in patients without liver disease. Check out our acute and chronic liver disease DDX videos for a discussion of the many underlying conditions that can cause acute and chronic hepatocellular disease, viral hepatitis of all shapes and sizes, metabolic disorders, autoimmune hepatitis, the works. Next up, Wait, what does that say? Cole, Stacy, Pat, Ern. Ah, yeah, the cholestatic pattern of lab abnormalities. This is seen in, well, disorders in which the primary issue is impaired bile flow. You know, stasis of your coli. This time, ALK Phos is disproportionately elevated compared to the AST and ALT. Hence the oversized chalkboard towering over the toasting malt glasses. The ALK Phos is usually markedly elevated, more than 4 times the upper limit of normal. In contrast, AST and ALT are normal or mildly elevated. Not surprisingly, GGT will be elevated as well. Remember, an elevated GGT can be used to confirm the hepatic origin of an elevated ALK Phos, particularly useful if other tests, like AST and ALT, are normal. GGT won't be elevated if the ALK Phos is derived from bone. Elevated bilirubin and jaundice are prominent features of moderate to severe cholestatic disease, hence the relaxed jaundice billy goat up there. Keep in mind that bilirubin may be normal in early disease or with intermittent biliary obstruction. Impaired bile duct flow means that conjugated bilirubin is trapped on its way out of the liver. So expect a conjugated hyperbilirubinemia, as emphasized by the collar on that billy goat. Prolonged severe cholestasis can present with a prolonged PT and elevated INR as well. So we've brought in another one of those INR intercom radio thingies. Why the elevated INR? Well, cholestasis leads to decreased absorption of fats, including fat soluble vitamins such as vitamin K. Without sufficient vitamin K, hepatocytes are unable to synthesize vitamin K dependent coagulation factors in the extrinsic pathway. Since vitamin K deficiency is responsible for the elevated INR, a single injection of vitamin K should correct the abnormality within 24 hours. Nice! Compare this to the elevated INR seen in hepatocellular disease, which does not correct with vitamin K. Cholestasis of any cause can also present with pruritus. The exact mechanism is unknown, but it may be related to elevated levels of bile acids. The classic cholestatic lab pattern is seen in two broad categories of disorders. See that clogged green feeder outside the liver enclosure? It represents obstruction of the bile ducts outside of the liver, also known as extrahepatic cholestasis, while that clogged feeder inside the enclosure represents intrahepatic cholestasis, the disruption of bile ducts inside the liver. Yep, intra and extrahepatic cholestasis look the same on laboratory testing. How do you tell them apart? Right upper quadrant ultrasound. In patients with a cholestatic lab pattern, ultrasound is typically the next best step of the workup. Extrahepatic cholestasis often presents with dilated bile ducts as a result of increased intraductal pressure behind the site of obstruction. Depending on the location of the obstruction, the dilated ducts may be extrahepatic or intrahepatic or both. To remind you that duct dilation is a feature of extrahepatic cholestasis specifically, we've placed this dilated green windsock outside the liver pen. In contrast, the bile ducts usually appear normal in intrahepatic cholestasis. One of the most common causes of extrahepatic cholestasis is gallstones within the common bile duct, also known as choledocholithiasis. Patients present with prolonged episodes of right upper quadrant or epigastric pain, accompanied by nausea and vomiting. Some may also have jaundice. Passage of the stone relieves the symptoms. As with other causes of extrahepatic cholestasis, abdominal ultrasound may demonstrate bile duct dilation. In this case, dilation of the common bile duct. Occasionally, the gallstone itself may be detected in the duct as a hyperechoic, bright spot with shadowing. However, overlying bowel gas can get in the way, making it difficult or even impossible to see the stone. Up next, acute cholangitis, which involves inflammation and bacterial infection of the bile ducts. It's represented here by this unexpected flame dangerously close to that biliary windsock. Acute cholangitis usually develops in the setting of biliary stasis from underlying bile duct obstruction. The most common cause of this obstruction? A stone lodged in the common bile duct. Yep, choledocholithiasis. Other major causes include malignant obstruction and benign biliary strictures. Acute cholangitis classically presents with three findings, a triad, if you will: jaundice, right upper quadrant pain, and fever. This combo is referred to as Charcot's triad, represented by the triangular dinner bell and fashionably short coat. Not surprisingly, acute cholangitis often presents with leukocytosis, a sign that distinguishes it from all other cholestatic disorders. So we've drawn in a few elevated leukocyte white birds. Abdominal ultrasound may demonstrate biliary dilation, or, if you're lucky, more specific signs of the underlying etiology. Obstruction of the extrahepatic bile ducts by cancer is another relatively common cause of extrahepatic cholestasis. So pay attention to that shiny cancer crab belt. Two important malignancies here. First, exocrine pancreatic cancer. In particular, tumors arising from the pancreatic head tend to obstruct the common bile duct relatively early. And second, cholangiocarcinoma, or bile duct cancer, which can arise from any part of the biliary system, but primarily affects extrahepatic ducts. Malignant obstruction is classically associated with painless jaundice, but patients can also present with pain and jaundice, as depicted by these twin cowboys, one happily wrestling with the yellow billy goat to represent painless jaundice, and the other twin getting nipped by a yellow billy goat to represent pain and jaundice. When pain is present, the location depends on the type, usually epigastric with pancreatic cancer, and right upper quadrant in cholangiocarcinoma. Like many malignancies, pancreatic cancer and cholangiocarcinoma commonly present with weight loss. Hence the excessively thin, frail constitution of this goat here. Just none at anything in sight. Ugh. And you know what's worse than getting nipped by a sickly, jaundiced goat? Getting nipped by a sickly, jaundiced goat while it defecates on your leg. Patients with malignant obstruction may report unusually light, clay colored stools. Why? Compared to other causes of extrahepatic cholestasis, malignancy is more likely to cause complete or near complete obstruction. The result? Little to no bilirubin reaching the intestines. Normally, bilirubin is metabolized by gut bacteria into urobilinogens, which, once oxidized, are converted into the pigmented molecules urobilin and stercobilin, responsible for the brown color of stool. Without these pigments, the stool appears clay colored, or acholic. Pale stool is often accompanied by dark urine as a result of high urine bilirubin levels. As mentioned earlier, conjugated bilirubin can be excreted into the urine thanks to its water solubility and relatively small size. Complete biliary obstruction leads to very high levels of both unconjugated and conjugated bilirubin in the serum. As a result, large amounts of conjugated bilirubin spill into the urine, making it appear dark. Ugh, just look away. Classically, malignant obstruction also presents with Courvoisier sign, a non tender, palpable gallbladder in a jaundiced patient. Or in this case, a jaundiced rassled goat playfully head docked at the cowboy's upper right abdominal quadrant. The mechanism? Malignant obstruction produces chronically elevated intraductal pressures. As long as the obstruction is distal to the cystic duct, the pressure backs up all the way to the gallbladder, causing it to become distended. In reality, this sign is present in only a fraction of patients with malignant obstruction. In addition, any prolonged severe obstruction distal to the cystic duct can lead to Courvoisier sign. That said, its presence does make cancer more likely than an intermittent obstructive process like choledocholithiasis. On ultrasound, malignant obstruction usually produces bile duct dilation behind the site of obstruction, just like other causes of extrahepatic cholestasis. In addition, ultrasound may demonstrate a mass in the pancreas or bile ducts. It's not just stones in cancer. Parasites can obstruct the bile ducts too. The large roundworm, Ascaris lumbricoides, is embodied by the Oscar's lumbricoat truck. Ascaris lumbricoides is a common cause of extrahepatic cholestasis in some developing countries. Adult worms primarily inhabit the small intestines, but can migrate through the papillae into the large bile ducts. Although rare in the United States, this worm affects nearly 1 billion people worldwide. Yep, that's right, billion with a B, and an I, and a. Okay, I think you get it. But a lot of people. Fortunately, most are asymptomatic. Still, a staggering number. The majority of cases are in Asia. So consider ascariasis on your differential in patients with a history of immigration from or travel to this area of the world. The worm is acquired by ingesting water or food contaminated with eggs. Thanks to their large size, these worms are readily apparent on imaging, including abdominal ultrasound. Look for long, linear, parallel structures within the bile ducts, not unlike these large, long pieces of lumber. In general, ascariasis can be confirmed by finding ova on stool microscopy. So we've drawn in some farming equipment that looks microscope-esque, to say the least. In addition, patients may report seeing adult worms in their stool, a sight unlikely to be forgotten. Clonorchis sinensis, a flatworm known as the Chinese liver fluke, can cause both intra and extrahepatic cholestasis. In particular, adult flukes have a predilection for the small ducts within the left lower lobe of the liver. Just think of this clon orca here, inhabiting the left side of the liver-shaped map. Adult flukes can live in the bile duct for decades. Chronic exposure to large numbers of flukes leads to diffuse bile duct injury, as well as physical obstruction of ducts by adult flukes. Clonorchis is acquired from ingestion of undercooked fish. It's endemic in parts of East Asia, including China. Since symptoms of biliary obstruction primarily occur in patients with chronic, repeated exposure to a large number of flukes, Clonorchis infection should be on your differential if a patient has emigrated from an endemic area. On ultrasound, the flukes may be visible as little echogenic, i.e., bright, spots within the biliary tract. In addition, bile duct dilation and gallbladder distension are common. Again, look at that poop. Clonorchis infection can be confirmed by finding ova on stool microscopy. Next up is primary sclerosing cholangitis, symbolized by that green biliary sclerotic snake. This is a chronic inflammatory disease characterized by fibrosis and stricturing of the bile ducts. In most cases, both the intra and extrahepatic ducts are affected. So we're talking both intra and extrahepatic cholestasis, which is why we've placed this dude on the fence of the liver pen. It predominantly affects men, and the majority are diagnosed in their 30s and 40s. Many patients also have ulcerative colitis. Because of this association, a history of ulcerative colitis, or classic symptoms such as bloody diarrhea, should raise your suspicion for PSC. Ultrasound may demonstrate focal bile duct dilations or bile duct wall thickening, but also can be normal. And finally, back inside the liver pen for one more cholestatic disorder, this time affecting only the intrahepatic bile ducts. As a reminder, in the setting of intrahepatic cholestasis, the bile ducts usually appear normal on ultrasound. Primary biliary cholangitis is an autoimmune disease characterized by destruction of intrahepatic bile ducts, eventually leading to intrahepatic cholestasis. About 90% of affected patients are female, and most are diagnosed in their 40s and 50s. The hallmark serologic test for PBC is the presence of antimitochondrial antibodies. They are both sensitive and specific for this diagnosis, so they're present in almost all patients with PBC. A negative test effectively rules out PBC. All right, it's time for our third and final pattern of abnormal laboratory findings: isolated hyperbilirubinemia. This refers to elevated bilirubin in the setting of normal AST, ALT, ALK-Phos, and GGT. No liver injury or cholestasis here. This pattern can present with either unconjugated or conjugated hyperbilirubinemia. Let me show you what I mean. Think of the isolated collared goat as isolated conjugated hyperbilirubinemia. This is a relatively rare finding. It's seen in two autosomal recessive inherited disorders: Dubin-Johnson syndrome and Rotor syndrome, symbolized here by the garbage bin and the rotor windmill. The underlying mechanisms are different. Dubin-Johnson is caused by a defective bilirubin transporter, while Rotor is a result of impaired reuptake of conjugated bilirubin. But the end result is similar: decreased excretion of conjugated bili into the bile ducts. So it builds up in the serum instead. Classic conjugated hyperbilirubinemia. Both disorders present with jaundice, usually starting in the second decade of life. Patients are otherwise asymptomatic, a bit like this young, happy lad, and don't require treatment. In fact, it's not even necessary to distinguish between the two disorders. That's it for isolated conjugated hyperbilirubinemia. In contrast, isolated unconjugated hyperbilirubinemia is far more common. Yep, we've come full circle, back to our first uncollared, unconjugated goat, wreaking havoc. Hemolysis, represented by these splattered tomatoes, is an important cause of isolated unconjugated hyperbilirubinemia. Remember, bilirubin is a breakdown product of heme. In hemolysis, premature destruction of red blood cells leads to increased production of unconjugated bili. In the setting of brisk hemolysis, even a normal liver can't process the unconjugated bilirubin fast enough, so it builds up in the blood. Both intravascular and extravascular hemolysis can increase the unconjugated bili. Disorders may be either inherited or acquired. A few additional labs can determine if hemolysis is to blame. Clinically significant hemolysis presents with anemia. Look for a decreased hemoglobin and hematocrit on a CBC, represented, as always, by that falling H&H abacus. Also, look for laboratory evidence of hemolysis, including an elevated reticulocyte count, as the bone marrow attempts to compensate by increasing RBC production. At Sketchy, reticulocytes, or immature RBCs with large lacy nuclei, are symbolized by large lacy teabags inside of RBC-shaped teacups. Also look for an elevated serum lactate dehydrogenase because of release by hemolyzed RBCs. Also check for a low serum haptoglobin, because haptoglobin binds to free hemoglobin and is rapidly cleared from the blood. Just think of this happy haptoglobin sign broken and low to the ground. In addition, the peripheral smear may display abnormally shaped RBCs, like schistocytes or bite cells, depending on the underlying etiology. Check out our hemolysis sketches for more info on this topic. Isolated unconjugated hyperbilirubinemia can also be drug-induced. Rifampin and probenecid are some of the most common culprits, symbolized by this rifampin rifle and probenecid probe. Both of these drugs increase serum unconjugated bilirubin by impairing hepatic uptake of unconjugated bili from the circulation. This is reenacted by this uncollared goat here denied entry into the liver pen. Gilbert syndrome is another cause of isolated unconjugated hyperbilirubinemia, embodied by old farmer Gil, up to his usual antics and chasing after that uncolored goat. This is a common inherited condition, affecting 3 to 7% of Western populations and generally first presents in adolescence. This autosomal recessive disorder is characterized by reduced activity of UDP glucuronylsyltransferase, the enzyme responsible for conjugating bilirubin within the hepatocyte. The result is mild impairment in conjugation of bilirubin. He just can't get that collar on the goat. Gilbert syndrome presents with intermittent episodes of jaundice and mild unconjugated hyperbilirubinemia. Episodes can be triggered by events such as illness, fasting, physical exertion, stress, or menses, which is why we've emphasized the trigger at his side. Patients are asymptomatic between episodes. An otherwise healthy adolescent or adult with mild unconjugated hyperbilirubinemia, no evidence of hemolysis, and normal liver tests can be presumed to have Gilbert syndrome without the need for genetic testing. The condition is benign and doesn't require treatment.